Okay, take a deep breath. We are doing this. We are tackling the absolute beast of the MD anesthesiology syllabus today.
It is a beast.
I've got my notes from Miller, I've got Guyton open to the membrane physiology chapter, and I've got a stack of ICU protocols that look, frankly, terrifying. We are doing a dedicated exam prep session on sodium and potassium disorders.
It's good to see you taking this so seriously.
Yeah.
Because let me tell you, as a senior faculty member and, well, an examiner, this topic, electrolytes,
Yeah.
it's where we catch people.
That's what I hear.
It is a guaranteed Viva trap, and it is a very, very frequent 20-mark theory question.
Yeah.
If you don't really understand the physiology, you just can't manage the patient in the ICU or the OT. It's that simple.
That is exactly why I asked you to do this sort of a mock Viva/deep dive with me. My goal here is to just conquer the Gujarat University MD anesthesiology exam requirements for this specific topic.
Good.
I really want to move beyond just, memorizing normal values. I want to understand the why and the specific anesthetic management that you, the examiner, are actually looking for.
Then let's treat this like a high-level tutorial. We're essentially synthesizing data from, Miller's anesthesia, Guyton's physiology.
Harrison's as well, and the Oxford Handbook of Critical Care.
Right. We need to cover the physiology, the clinical features, and most importantly, the safe management. That's the key word, safe. So where should we start?
We have to start with Part A, sodium disorders, and I think the best place to begin is the introduction, the exam framing. Why do we, as anesthetists, care so much about sodium?
We care because sodium is, it's the skeleton of your extracellular fluid. It really is.
That's a skeleton. I like that.
Guyton makes a very specific point here that you should quote. Sodium and its associated anions, they account for over 90% of the solute in the extracellular fluid.
Over 90%.
So think about that. It means sodium is the principal determinant of your ECF osmolality and therefore your ECF volume. If your sodium is wrong, your volume status is usually wrong. Or worse, your brain is swelling or shrinking.
Right. And from a neuronal perspective, Guyton also emphasizes the Nernst potential, the sodium gradient. That's what drives the upstroke of the action potential.
Exactly.
So severe sodium disorders aren't just about fluid. They're about whether your nerves can even fire properly.
Precisely. For the anesthetist, this is absolutely critical. We care about fluid shifts, we care deeply about cerebral edema, and we care about delayed awakening post-op.
Okay, so in the exam, if I get a long answer question on this, how should I structure it?
You structure it logically. You start with physiology, then the specific disorder, say hyponatremia, and then management. Always in that order.
Physiology, disorder, management, got it.
But in the Viva, I'm going to focus on the traps.
Yeah.
I'm going to ask you about the risks of rapid correction, and maybe throw in a curveball like TURP syndrome.
Okay, let's hit the physiology first then. This is labeled very high yield in my outline, so balance and regulation.
To keep it simple for the exam, regulation comes down to two main things, content and concentration.
Content and concentration.
Yes. Guyton really emphasizes this. Aldosterone regulates the amount or the content of sodium. It tells the kidney, hey, hold on the salt.
Right, the RAS system.
But, and this is the key distinction, ADH, or antidiuretic hormone, it regulates the concentration of sodium. It does this by telling the body to hold on to water.
Okay, so aldosterone for salt content, ADH for water and concentration.
You've got it. Miller explains that mechanism really well. ADH causes the insertion of aquaporin 2 channels in the collecting ducts.
Which allows free water reabsorption?
Exactly. So if my sodium concentration is too high, my osmolality goes up, ADH kicks in, I hold on to water, and I dilute the sodium back down to normal.
And thirst is the behavioral backup for that.
Thirst is the ultimate backup, yes. Now here is a distinction you absolutely must make in a theory paper. Osmolality versus osmolarity.
Okay, I have this written down. Miller defines osmolality as osmolase per kilogram of solvent, and osmolarity as osmolase per liter of solution.
And which one do we usually calculate at the bedside?
We calculate osmolarity. In the body, they're very close, but clinically, we use the formula.
Which is?
The formula is 2 times the sodium plus glucose divided by 18 plus BUN divided by 2.8.
You need to have that formula memorized. It's your bread and butter because it tells you right there that sodium multiplied by 2 is the main driver of tonicity.
Right. It's the biggest component.
So if you have a patient with a sodium of, say, 120, their tonicity is low, and that means water is going to move. Which brings us to the core of the exam. Hyponatremia.
Okay. Hyponatremia. Defined as serum sodium less than 135 mUqL. We classify it by severity. Mild is 130 to 134. Moderate is 120 to 130.
And severe.
Severe is less than 120. But the diagnostic classification, the one that I know examiners love, is based on volume status, the Harrison's flow chart.
Yes. If you are going to draw a single diagram in your exam answer for sodium, draw the Harrison's algorithm. You divide patients into hypovolemic, euvolemic, and hypervolemic. Walk me through them.
Okay, so hypovolemic hyponatremia. This means you've lost both water and salt, but you've lost more salt than water.
Good. What are the causes?
Causes would be diuretics, especially thiazides are notorious for this. GI losses like severe vomiting or diarrhea, or something more complex like cerebral salt wasting.
Very good. Now, euvolemic.
Euvolemic is where you have an increase in total body water, but the total body sodium content is pretty much normal. The water just dilutes it.
And the classic causes.
SIADH, syndrome of inappropriate ADH. Miller lists a whole bunch of perioperative triggers for SIADH. Pain, nausea, opioids, trauma, and just the general post-op stress response.
That is a crucial point for us. Remember that. Surgery is a trigger for SIADH.
Yeah.
So seeing a patient with a sodium of, say, 132 post-op is not uncommon, and you need to know why.
Okay, and what about hypervolemic?
That's where you have way too much water and also too much salt, but the water overload is way worse than the salt overload. So you're edematous.
This is your heart failure patient, your cirrhosis patient, nephrotic syndrome, the classic third spacing edematous states.
Correct. Now, there are two special situations I want to highlight. One is pseudohyponatremia. Tell me about that.
Ah, right. Harrison's notes this can happen with really high levels of lipids or protein in the blood, hyperlipidemia or hyperproteinemia.
And what does that do?
It makes the sodium look low on the lab report, but the plasma osmolarity is actually normal.
So do we treat that with hypertonic saline?
No, absolutely not, because the tonicity is normal. It's a lab artifact. You'd cause massive harm.
Good. You avoided that trap. The second situation is purely anesthetic, TURP syndrome.
Right. Transurethral resection of the prostate. This happens because of the absorption of the irrigation fluid, which is usually glycine.
And what does that glycine do?
It's hypotonic, so its absorption causes a rapid, acute dilutional hyponatremia.
And glycine has its own toxicity, causing visual disturbances and confusion. But physiologically, it acts like you've just given the patient a massive water load. Now let's talk clinical features. What does the patient with hyponatremia look like?
It's all about the CNS. The symptoms are predominantly neurological. It starts with things like nausea, malaise, maybe a headache. As it gets worse, you see lethargy, confusion, and then eventually seizures, coma, and even brainstem herniation.
And what determines the severity of those symptoms, the absolute number?
Not just the number. Miller states that symptoms typically appear below 120, but it depends heavily on the rate of the fall. An acute drop is much, much more dangerous than a chronic, slow one.
That is the golden rule. Why? What's happening in the brain?
Acute hyponatremia causes rapid cerebral edema because water rushes into the brain cells following the osmotic gradient. The brain cells haven't had time to adapt.
And in chronic hyponatremia?
The brain has had days to adapt. The cells get rid of their own internal solutes osmolates to balance the pressure so they don't swell as much.
Excellent. This distinction is what dictates your entire management plan. So you're in Aviva. How do you diagnose the cause of hyponatremia? Give me the steps.
Okay, step 1. Check the serum osmolality. That's to rule out pseudohyponatremia.
Good. Step 2.
Step 2. Assess the patient's volume status. Clinically. Are they dry? Are they euvolemic? Are they overloaded?
And step 3.
Step 3. Check the urine electrolytes, specifically the urine sodium.
Okay. Interpret the urine sodium for me. What does a low urine sodium tell you?
A low urine sodium, say less than 20, means the kidneys are working properly. They're trying to hold on to sodium. This suggests an extrarenal loss, like vomiting or avid retention, like in heart failure.
And a high urine sodium.
A high urine sodium greater than 20 suggests the kidneys are the problem. They're inappropriately wasting sodium. This points to things like diuretics, cerebral salt wasting, or SIADH.
Perfect. Now for the most important part, management. This is marked very high yield. You have a patient with acute symptomatic hyponatremia. They're seizing in front of you. What do?
This is an emergency. Urgent correction is required. I'd use hypertonic saline, 3%.
How would you give it?
Miller suggests small boluses, maybe 100 millilo, or a slow infusion, just enough to arrest the seizures. The goal isn't to normalize the number, it's to stop the acute symptom.
And you have to be incredibly careful about what?
The rate of correction.
This is the biggest trap in the entire exam. If you correct it too fast, what happens? Tell me the name of the syndrome.
Osmotic demyelination syndrome, or ODS. It used to be called central pontine myelinolysis.
And what is that?
It's a disaster. Basically, if you raise the serum sodium too fast in a chronically hyponatremic brain, water rushes out of those adapted brain cells. They shrink and demyelinate. And what's the clinical outcome?
It can cause a locked-in syndrome. It's devastating. So what is the safe rate of correction, the number you will state in your exam?
The crucial rule is do not correct faster than 8 to 10 MEQ per liter in 24 hours.
8 to 10. Good.
Miller actually leans conservative, suggesting we should aim for closer to 8. Even if they are seizing, the plan is to bump the sodium up by just a few points, maybe 2 to 3 MEQ, enough to stop the seizure, and then you have to slow right down.
Excellent. Safety first,
Yeah.
always. And for a stable patient with SIADH, what's the cornerstone of management?
Fluid restriction, not necessarily saline, unless they are severely symptomatic.
Very good. Now let's flip the coin. Hypernatremia.
Okay. Sodium greater than 145 millieql.
What's the underlying problem here usually? Is it too much salt or too little water?
It's almost always a water deficit problem.
Right.
It can be a lack of intake, which we see all the time in our intubated, sedated ICU patients who can't ask for water, or it can be excess loss of water,
Like in
diabetes insipidus, DI,
Yeah.
whether it's central or nephrogenic.
In the ICU, we also often see this from osmotic diuresis, say from mannitol use, or severe hyperglycemia, where glucose is acting as an osmotic agent.
And what's happening to the brain cells in hypernatremia?
The opposite of hyponatremia, they shrink. Water moves out of the cells into the hypertonic ECF.
And this can tear the bridging veins and cause a subarachnoid hemorrhage.
It can. So how do we manage this? What's the first step?
We have to calculate the free water deficit. There are formulas for it. And again, the rate of correction is everything.
What's the rule for the rate?
We have to correct it gradually, over 48 to 72 hours. The maximum rate of fall should be about 0.5 millieq per liter per hour. Why so slow? What are we trying to avoid?
We're trying to avoid cerebral edema. If we drop the serum sodium too fast with free water, water will rush into those shrunken brain cells and they can swell and even burst.
Exactly. Rehydration is the key, but it has to be slow. What fluids would you use?
Oral water is the best if the patient can drink and the gut works. If not, then IV fluids like D5W, which is essentially free water, or 0.45% saline.
Good. The Oxford Handbook specifically warns against dropping the osmolarity rapidly. So for hypernatremia, slow and steady absolutely wins the race.
Okay. I think that covers sodium fairly well. Let's move to Part B, potassium disorders. This to me feels even more high stakes because of the direct cardiac risk.
It is. If sodium is the brain, potassium is the heart. It's all about membrane potential. Let's start with the physiology. Distribution is the key concept here.
Right. 98% of all the potassium in the body is intracellular, inside the cells. Only 2% is in the extracellular fluid. And that tiny ECF amount is what we measure. What maintains that huge gradient?
The Na plus K plus AT pace pump. It's constantly pumping sodium out and potassium in.
So because the ECF pool is so small, what does that mean for serum levels?
It means that even tiny shifts of potassium, either in or out of the cells, can cause massive changes in the serum potassium level.
Exactly. And if you apply the Nernst equation, potassium is the primary determinant of the resting membrane potential of excitable cells, like nerves and cardiac muscle.
So that's why changes in potassium have such dramatic effects on the heart.
That's why. Now, how is it regulated?
Mainly by the kidneys. Aldosterone, again, stimulates potassium secretion in the distal tubule. Also, acid-base balance is huge.
So tell me about that.
Acidosis shifts potassium out of cells in exchange for hydrogen ions, which can cause hyperkalemia, and alkalosis does the opposite. It shifts potassium into cells, causing hypokalemia.
And there are two other key players.
Catecholamines and insulin. Both of them drive potassium into cells. This is really important for the body's stress response to surgery or trauma.
Good. Let's talk about hypokalemia. Potassium less than 3.5. What are the common causes?
Loss is common. Diuretics are a big one, loop and thiazides. GI loss from vomiting or diarrhea. And then there's a key one, magnesium deficiency.
Why is that important?
Because if you have a patient with refractory hypokalemia, one that you just can't seem to correct with potassium replacement, you have to check the magnesium level. Low magnesium prevents the kidneys from retaining potassium properly.
An excellent point. Now, for anesthetists, we need to know the clinical features. Muscle weakness, ileus, yes. But what are we most worried about?
The cardiac issues. Delayed repolarization, which predisposes to reentrant arrhythmias like torsades de pointe.
Okay, this is a classic Viva request. Describe the ECG changes of hypokalemia in progression.
Okay, describing the progression. First, you tend to see flattening or even inversion of the T waves.
Okay.
Then the appearance of prominent U waves, which appear after the T wave. That's the hallmark
Wow,
sign.
the U waves, good.
You might also see ST segment depression and eventually a prolonged QU interval.
Correct. So how do we manage this?
Well, oral potassium is much safer, if possible. If we need to use UV, we have to be careful. It's painful and can cause phlebitis.
What's the maximum safe rate of infusion through a peripheral line?
The maximum rate is generally considered to be 10 to 20 milliUQ per hour. If you need to give it faster than that or in a higher concentration, you really need a central line.
Good. And what are the specific anesthetic precautions you need to take with a hypokalemic patient?
Okay, two big ones. First, avoid hyperventilation.
Why?
Because hyperventilation causes respiratory alkalosis, which drives potassium into the cells and makes the hypokalemia even worse.
Perfect. And the second one?
Be really careful with glucose-containing fluids. The insulin release that's stimulated by the glucose will also shift potassium into the cells.
Very good. Now for the big one, hyperkalemia, potassium greater than 5.5. This is an exam favorite because it kills patients quickly and dramatically.
Okay, causes. Renal failure is the most common cause by far.
What else?
Drugs. Things like ACE inhibitors, ARBs, spironolactone, NSAIs, and of course, succinylcholine.
Specifically in which patients is succinylcholine dangerous?
In patients with burns, massive trauma, or denervation injuries, because they have an upregulation of extrajunctional acetylcholine receptors, giving them sucks can cause a massive, life-threatening release of potassium.
What else can cause it?
Massive tissue breakdown, things like rhabdomyolysis, tumor lysis syndrome, or even just a hemolyzed blood sample giving you a falsely high reading.
Yes, pseudohyperkalemia.
Yeah.
Always consider it. What about the clinical features?
It can cause an ascending muscle weakness or paralysis, but the heart is the primary killer. It can cause bradycardia, heart block, ventricular fibrillation, and asystole.
You must nail the ECG changes for the exam. Give me the classic sequence.
Okay. The very first early sign is tall, peaked T waves. They're often described as tented T waves.
Right. What's next?
As it gets worse, the PR interval prolongs and you start to lose the P waves. They just kind of flatten and disappear into the baseline.
And in the late pre-arrest stages.
This is where the QRS complex widens and starts to merge with the T wave. This forms that really ominous sine wave pattern.
That sine wave pattern is the death rattle of the heart on an ECG. If you see that, you have seconds to act, not minutes.
Okay, so emergency management, the classic 3 steps. What are they?
Step 1 is membrane stabilization.
What do you give?
IV calcium, either calcium gluconate or calcium chloride.
And what does the calcium do? Does it lower the potassium level?
No. And this is a crucial distinction to make. It does not lower the serum potassium. It antagonizes the effect of potassium on the cardiac membrane excitability. It basically protects the heart and buys you time. The effect is almost immediate.
So calcium protects the heart. It doesn't fix the potassium. Got it. What is step 2?
Step 2 is to shift the potassium intracellularly. Get it out of the plasma and back into the cells.
And how do we do that?
We use insulin, usually 10 units of regular insulin, plus dextrose, like 50 milliliters of D50, to prevent hypoglycemia. We can also use beta-agonists, like a salbutamol nebulizer, and if the patient is acidotic, we can give sodium bicarbonate. And step 3, the final step.
Elimination. We have to get the excess potassium out of the body for good.
Yeah.
We can use loop diuretics like furosemide if the kidneys are working. We can give potassium-binding resins, although they're quite slow. And the definitive treatment, especially in renal failure, is dialysis.
Excellent. In a cardiac arrest situation with suspected hyperkalemia, you're not doing these one by one. You're doing all of these things simultaneously.
That makes sense. And that leads us nicely into Part C anesthetic and ICU considerations. Let's talk about the preoperative evaluation. When do we actually cancel an elective case for an electrolyte abnormality?
It's a clinical judgment, but as a general rule, a potassium less than 3.0 or greater than 5.5 makes us very nervous for elective surgery. For sodium, the numbers are a bit more flexible and depend on chronicity.
And Miller emphasizes optimizing chronic imbalances slowly, right?
Absolutely. You don't want to cause big, rapid fluid or electrolyte shifts right before you induce anesthesia. It's asking for trouble.
Okay, and drug interactions are huge. We mentioned succinylcholine. What about the non-depolarizing muscle relaxants?
Hypokalemia potentiates them. So a patient with a K of 3.1 might be much more sensitive to your rocuronium.
And digoxin.
That's a classic. Hypokalemia dramatically increases the risk of digoxin toxicity.
Right. And you mentioned local anesthetics are influenced by sodium channels, but that's more theoretical.
It is, but it's good to be aware of the principle. Now, in the ICU, we often talk about sick cell syndrome. What is that?
It's a state you see in really critically ill patients with sepsis or ischemia. The innate hump starts to fail due to a lack of ATP.
So sodium accumulates inside the cell and potassium leaks out.
Exactly. The cells swell, and the patient can develop hyponatremia and hyperkalemia simultaneously. It's a very poor prognostic sign. This is why frequent monitoring with an ABG or electrolyte panel is essential in the ICU. And that's also why there's a big push to use balanced salt solutions like plasmolite or Ringer's lactate instead of just normal saline.
Yes, because large volumes of normal saline can cause a hyperchloremic metabolic acidosis, which can then worsen hyperkalemia. It's all connected.
Okay, let's wrap up with the most important part for me right now. Common exam questions and Viva traps. What are the pitfalls students constantly fall into?
The traps you and I have already talked about.
Okay.
Trap number 1, rapid sodium correction. If a student eagerly says, oh, the sodium is a 110, I'll give hypertonic saline to get it to 135 in the next 6 hours, that's an immediate fail.
Because of the ODS risk.
An immediate dangerous fail. What's another one?
Treating the number instead of the patient.
Explain.
Well, if a patient has a chronic asymptomatic hyponatremia of 128, they don't need aggressive treatment with hypertonic saline. You need to investigate and treat the underlying cause slowly.
Exactly. And the third big one is what I call ECG blindness. If I give you a Viva scenario with a patient whose potassium is 6.5, what is the very first thing you must ask for?
An ECG.
An ECG. Before you even think about insulin or calcium, you need to know what the heart is doing right now. If you start rambling about management before assessing the immediate cardiac risk, you've missed the entire priority of the situation.
That makes perfect sense. Assess for imminent danger first. I should also remember to think about pseudohyponatremia in a patient with lipemic serum, like from pancreatitis or TPN. Don't treat a lab error.
Exactly. Finally, let's talk about presentation. Visualizing the answer. In a written exam, you need to use diagrams. They break up the text and show the examiner you can think visually.
Okay, this is marked very high yield. What should I draw?
For hyperkalemia, you must draw the ECG strip progression. A little sketch showing a normal beat, then a peak T wave, then the wide QRS, and finally the sine wave.
Peak T to sine wave. Got it.
For hyponatremia, you should draw a simplified version of the Harrison's algorithm. A flowchart starting with measure serum osmolarity, then branching based on volume status.
And for physiology?
You could draw a simple diagram of a cell membrane showing the Nike pump and the concentration gradients, mentioning the Nernst potential. Those 3 diagrams can get you 3 or 4 extra marks easily.
Okay, so to summarize everything, sodium is primarily about volume and CNS symptoms. It's fundamentally a water problem.
Yes.
Potassium is about the membrane potential and cardiac arrhythmias.
The heart.
For hyponatremia treatment, the absolute mantra is watch the rate, less than 8 to 10 male EQ per day.
Crucial.
And for hyperkalemia emergency treatment, it's a 3-step priority. Calcium, first to protect the heart, then shift the potassium into cells, then eliminate it from the body.
That is a rock-solid summary. My final word to you as you head into this exam is this. Prioritize safe anesthesia over perfect numbers. The examiner wants to know that you won't harm the patient by chasing a lab value too aggressively.
Wow. Okay.
That
was intense, but I feel so much clearer now. We covered a massive amount of ground: physiology, pathology, pharmacology, and critical care management.
We did. It's a very dense topic. But if you remember one final nugget, let it be this. Electrolytes are the language of the cells. As anesthetists, we are the translators.
I like that.
If you can translate what that sodium and that potassium value are telling you about the patient's volume status and membrane stability, you will not only pass, you'll pass with flying colors.
Language of the cells. I'm going to go draw those diagrams right now while this is all fresh in my mind. And for anyone listening who's prepping for exams, seriously, grab a pen and sketch out that hyperkalemia ECG progression right now. It sticks so much better when you actually draw it yourself.
Absolutely. Good luck with your preparation.
Thanks for listening to this deep dive. We'll catch you in the next one.